Good afternoon. I would like to thank you all for joining us today. This is our last session of our Pediatric Roundtable series with the Lurie Children's Heart Center. I'm Julie Cooper-Brenner, and I'm one of the physician liaisons with Lurie, and I cover the west and northwest suburbs. Today, I am delighted to introduce you to Dr. Koenig, who will be talking about heart murmurs. At the end of the presentation, we will have some time for question and answer, so please feel free to use the question box or the chat box, and we can raise those questions to Dr. Koenig. I would now like to introduce Dr. Koenig. Thank you.
Everybody see me? Okay, we're ready to go. Thank you. Let me just pull this up and we're moving. Let's pull this something out of the way. I've got to dismiss something back here. Okay, thank you. I'm going to be talking about murmurs and the use of testing. And let's make sure I'm on here. It's not working here. Where's my PowerPoint? I've got nothing to disclose. And so my objectives in short order are to really embrace the concept of murmurs without really talking about all the murmurs in detail, add some structure to the murmur evaluation, go over some testing pros and cons, and note that I'm anticipating that viewers are going to pause parts of the webinar to be viewed later. So I'm not going to read every word of the slides. You can replay it later. Got reference at the end for further reading and thought, for murmur evaluations and some tips, some evidence in the use of tests. I've got articles regarding the current state of training and auscultation, as well as articles on artificial intelligence. So first of all, I just like to think really, bringing it down, and I looked at murmur. What is a murmur? And if you look in the dictionary, basically it's just a sound. So the murmur, is an atypical sound, and they've got the cardiac definition, but I'm thinking a murmur, the murmur of the brook, there was a murmur in the room, etc. And then if you go in the in Stedman's medical dictionary, and I put it here, their definition, but from the bottom line, from a cardiac standpoint, a murmur is the sound of blood flow and should not be misused as meaning more than that. And I think that's really important, and I really want to stress that concept, because that's what I do with parents a lot. And I'm going to point this out to everybody, maybe a tip to use when you're speaking to a parent. I like to bring out, I've heard say that, well, we all have a temperature, but sometimes people misuse the word. And, they think, oh, I've got a temperature. And I'm thinking, of course you do. What is it? Similarly, we all have blood flow, and blood flow typically makes noise as it flows. And as physicians, we want to be fancy, so we call it a murmur. And we should all have one. And I tell this to parents again and again. It sort of demystifies the word murmur. So to me, a cardiac murmur is the audible, auscultatory sound of blood flow. And then I use this analogy a lot, and I give this to everybody to use. Similar to cars, you may not always hear the sound of the engine in a Rolls Royce compared to maybe an MG. And similarly, we don't always hear blood flow in individuals due to them being very calm or being older. And I'm almost thinking bigger and larger, maybe a little fatter. But when you rev the engine, if the engine's louder, and that similar concept goes for murmurs. If you have fever, anxiety, and increased cardiac output, you may have a louder murmur, but there's nothing wrong. So loudness does not always make a murmur abnormal. And I have to stress that, because especially in the teenager who comes in all anxious, and they're anxious, I'm almost sure I'm going to have the murmur if they're nice and thin. So like the concepts. Having a murmur is not normal or abnormal. Having an innocent murmur is normal. There's no pathology. And when it's recognized, you should stress there is no need for further evaluation or testing. There's no restrictions, no follow-up. Don't need consultation unless there's some question or uncertainty. Simply need recognition and documentation of the murmur for oneself and perhaps others who may see the patient. And finally, there should be reassurance to the parents with an explanation, as I pointed out, normal sound of blood flow. If a murmur is not innocent, then by definition, it's pathology is implied, or you really don't know, and that may need more evaluation. So how do you figure out which is which? And I'm also going to talk about, do tests help in this evaluation? First thing is proper auscultation. So again, I'll point out, just like listening to a car engine, we have to decide which is normal or abnormal. The differentiation between normal and abnormal takes training. With experience, physicians should start to build a murmur repertoire. And I stress that. Over time, we have a bigger repertoire sorting out normal and abnormal. And so the first part, it's part of a lifelong endeavor. It never stops. The description of every murmur that you hear. And with experience and proper auscultation, you can describe things and allow categorization into innocent or not innocent. So how and what can we categorize? So I think I apply this. This is the discipline. And every time you hear murmur, I think you should really describe it well. First, the grade, and I'm going to go into details in grading. The quality, it's your own adjective. And I have lots of them: harsh, soft, puffy, squeaky, crinkly, sandpapery, crinkly, rubbery, honking, whistling, vibratory, etc. What it sounds like to you. For you, if you hear it again, what you think of. The length, is it short, medium, long, or holo? Timing, this is within the phase of the cycle. Is it early, mid, or late? And that only applies for short length or maybe medium length murmurs. And the phase, is it systolic, diastolic, both, or continuous? And these mean different things, but this is part of the description. The shape, is it crescendo, decrescendo, decrescendo? The geography, location, where it radiates to. Where is it just as loud as where you heard it initially? And this takes a little bit of understanding where the heart is and how blood flows. And finally, response or changes to maneuvers such as lying, standing, and squatting. And I do this with every patient, and I describe it fully, and I continue to refresh my exam skills. And for those interested, I've got references at the end. Once a murmur is described, it should be part of a mental catalog. The use of any tests, phoning a friend or getting another set of ears, etc., can help categorize murmur. It's part of the learning process in what is innocent and what's pathologic, i.e. things that you don't think are innocent. Comfort level and confidence is really important, and we should use that, all this categorization, and that should increase with experience. And there's evidence that the examination in experienced hands is fairly sensitive for detecting pathology, and it is relatively inexpensive. So if you examine, you've got the skills, you're trained, you should also have confidence. So what? The innocent murmurs to be learned and cataloged. So these are some things, and I don't have sound slides, but you should sort of recognize these following murmurs: a Stills murmur, a pulmonary flow murmur, a venous hum, cardiorespiratory murmur, which was really a breath sound, peripheral pulmonary stenosis or PPS, it's normal in the neonate, not normal at later on, and then some of the cranial carotid buoys. You're going to hear this in everybody. And there's reference in aids in murmur identification, again, at the end of my slideshow. So just an aside, the utility of the history, aside from the physical, the history cannot comment on the presence or absence of murmurs. That's a physical exam finding. However, what your history is useful for, it can provide clues to the possibility and severity of cardiac pathology. It helps triage. In the end, auscultation needs to stand by itself. You can have tachypnea, but you can have a normal murmur. So you need to put 2 and 2 together. So now going from the exam to testing. So the typical cardiac tests used for murmur evaluation and other things include ECGs, but doesn't have ears. And EKG doesn't hear, so can it help? How about a chest film? Doesn't have ears. Can it really help? How about an echocardiogram? In a way, it sort of has ears. There's an ultrasound probe, and sound is a common denominator, but in the end, an echocardiogram does not have ears. So you may have findings on the echo that doesn't correlate with the exam. So you could have a PFO or tricuspid valve regurgitation or a clinically silent PDA, but you may have a normal murmur. And vice versa. You could have a VSC, which you expect to hear, but you don't hear. Again, you have, again, a normal murmur. So your exam has to stand by itself. And there's the non-typical cardiac tests, which probably are not ordered by primary care providers. Things like transesophageal echoes, CTs, MRIs, and cardiac cath. That's probably in the purview of a cardiologist. But at least I'm going to go over the first 3. So ECGs, the theory, they measure voltage changes in the chest. And the hypothesis is that the ECG is an indirect way of assessing anatomy and therefore helpful in murmur evaluation. In theory, anatomic pathology of the heart, obstruction, enlargement, etc., should have a corresponding change in the voltage in ECG. But a lot of confounding factors. The thorax has variations from normal in the shape or thickness. Electrode contact may vary, and the heart, the heart may be in a different spot in the chest, may be rotated. And you also can have anatomic variations and maybe pathology that do not cause enough difference in the cardiac mass or changer size to register as voltage changes on the ECG. So it's helpful to know where ECG normal values come from. So a long time ago, Dalvin Young looked at a bunch of school-age children, and all they did is he plotted percentiles of various intervals and voltages with age. It was not based on anatomy. It's basically a voltage percentile rank. And historically, we've extrapolated the percentiles to have anatomic meaning. However, the ECG has never really been scientifically correlated with anatomic or anatomy or hypertrophy. So the theory really doesn't work, but we continue to do it to this day. How about the chest film? You know, chest x-rays go through the body, it's absorbed by film. We create shadows representing anatomic structures. For one thing, if the chest film is going to work, we have to have confidence that it accurately reflects chamber size and pulmonary vascularity corresponding to underlying physiology. So instance, an ASD, you should see right atrial, right-sided enlargement, maybe increased pulmonary vascularity, and a VSD, same but with left-sided enlargement. How about with aortic stenosis and pulmonary stenosis? Well, maybe if you can see a shadow of post-stenotic dilation of an artery. How about left ventricular hypertrophy? Would you really see increased thickness on a chest film? And how about lesser lesions, like a very small VSD or ASD? Is it going to have any significant change in the heart size or thickness? So is there data for this? So when I've talked to lots of radiologists, how they get normals from a chest film, and a lot of them have said, well, it's by experience. You sort of look at the shadows and we know it represents certain underlying structures, the ventricles, pulmonary, the arteries. But there hasn't been good evidence to correlate chest x-ray with size and hypertrophy. It tends to be subjective and reader dependent. And in adults, we always use the CT ratio, may not work as well for children. And if you're going to use a chest film, maybe if you want to make it more sensitive for cardiac pathology, at least add the lateral view. However, in the end, it still doesn't tell you about murmurs. It doesn't have ears. So echo, what's the theory and evaluation of the heart and murmurs? So in echo, ultrasound measurements, actually they correlate with anatomy, size and thickness. That's been shown. And also echocardiography, we use ultrasound and it can find abnormal blood flow. It has good correlation with truth. So it's indeed sensitive and specific for diagnosing most congenital heart disease. And there's lots of references, I'm not even gonna go over it because there's so many, but it works. But there's other issues. There's confounding factors in echo, very dependent on acoustic windows. It's dependent on proper acquisition and technical skills, so the sonographer needs to know what they're doing. It's dependent on proper interpretation, so who's gonna look at the echo, and you need proper equipment. Unlike the ECG and chest film, and even within confounding factors, an echo still, it's a great test for evaluating cardiac anatomy. But getting back to murmurs, gonna get there again, coming around. So physical exam versus testing. There's at least some evidence that the exam is sensitive, maybe not as specific, and it's relatively inexpensive. ECG can add to the sensitivity exam in diagnosing cardiac pathology and murmurs. It's also relatively inexpensive. Chest film may not add a lot more. It's also relatively expensive. So the bottom, what we all ask, and I ask, is it worth to even consider the utility of an echocardiogram, which is better, but it's a more expensive test? So let's talk about costs. And this was 10 years ago. I haven't really looked up costs of tests these days. I know it's higher. It's a guarded secret from most hospitals. They don't want to share that. But exam is relatively cheap. So you're coming in for a visit, maybe a couple $100, some very minimal costs. Plain film of the chest, maybe a couple $100. Same thing ECG. Cost of an echo 10 years ago, it was $1,600. I believe now it's a few $1,000s. So it's not cheap because you're paying for a machine, which may be $500,000. You're paying for a sonographer, you're paying physician. So I always ask, is it worth it? Is it appropriate for murmur evaluation? So there are published guidelines for use of the echo for murmur. And the conclusions, and this is also, they've got this consensus, It's rarely appropriate for a presumptively innocent murmur with no signs, symptoms, or findings of cardiovascular disease and a benign family history. It's appropriate for a presumptively innocent murmur with signs and symptoms or findings of cardiovascular disease, and it's appropriate for pathologic murmurs. Again, we get back to this presumptively innocent. Do you know it's innocent? Is it innocent or pathologic, and how do you find out? And then it results, the bottom line is your exam. Do you have confidence? Can you do a good exam? So some things to do if you're unsure, and this is some of my opinions. I think in a newborn, you have to be more careful. The murmur is usually not the thing for disease. You have to check your pulses and well-being and saturation. And if that's not there, everything looks fine, you probably have a little time because you don't have any critical findings. You have some time to think about it. And you've got another chance to listen to murmur again, not trying to get a lot of testing in the newborn period. You can always ask someone else in a group if you're new, you just finished residency. Maybe have someone else in the group listen, see what they think. Maybe someone more experienced. You consider additional testing in the presence of other symptoms. If you've got a tachypnic or desaturated patient or neonate, okay, now you've got something to go on. You're increasing the yield of an echocardiogram. So really, your history and other features are going to guide the time of further evaluation, if any. But in the end, you still cannot rely on testing. You can order an echocardiogram for a murmur, let's say, and the echocardiogram may show very small PDA, but when I listen to them, they've got an innocent Still's murmur. Had no correlation, so you have to still know how to correlate the test. Yeah, I would always say, when in doubt, if you're clearly pathologic with a murmur, it's time to refer for consultation. So I think at the time of referral, this is something I would put out for all the primary care providers. Make sure the parents know that an echocardiogram should not be an expectation. Sometimes I know they come to the office to see me and parents are expecting an echo, and I say, this is just a very loud Still's murmur, maybe out of the realm of what the primary care provider is comfortable with. But in my world, I'm still really comfortable. I don't want to have to talk the parent down if they're already expecting an echocardiogram. And I go into my spiel about sensitivity and specificity of tests and not opening up Pandora's box. So how about some of the newer tests? Why get a test at all? So I think testing in general, I use it to help triage or make a diagnosis. And maybe it can help manage uncertainty. It's that area that we all have to work on. The ideal test will be fast, inexpensive. Remember, I said echocardiogram is not really inexpensive. The other tests are, but do they help? A test should be easy to use and administer, supportable. No patient discomfort, 100% sensitive and 100% specific. We don't have that test. So I put this up there. If everybody remembers Star Trek, here's Dr. McCoy, here's the patient, and look here's his tricorder. He puts something on the patient. Okay, and this thing has all the answers to whatever's going on. This is what it looks like. So you've got this tricorder and a handheld. Bear with me, this is going to get to the point. And here's newer, I can't remember, this may be next generation or something. Here's the doctor. And now notice there's nothing on the patient. Here's the tricorder, something, and maybe they've got Bluetooth. And now in even the future, I can't remember which Star Trek, this Star Trek Voyager. This isn't even a doctor, this is a hologram. The emergency medical hologram still has a tricorder and then something else. And put that up there. I want to point out, because we're getting close to something like that, these are handheld ultrasounds, and they're out there. And so it's the size of a cell phone. Here's the probe, and you can actually, this is an echocardiogram. And I put that out there, just you got to put it on the table, and it's called Pocus, with a handheld size ultrasound to look at the heart that's designed to answer very specific questions to help triage. Things like, is the heart working, or are we in serious heart failure? Is there a pericardial effusion? It is not designed to be a comprehensive cardiac evaluation, certainly not a murmur use for typical murmur evaluation. It's probably not appropriate for murmur eval in the hands of a non-cardiologist, in my opinion. It's really more appropriate in the emergency room setting or in the ICU. I may use it for, if it comes around, and I think I will be using it, I'm going to use it in an extension of my exam after I've performed proper auscultation. And there's coming around this thing, it's an artificial intelligence stethoscope. It's a stethoscope that records the sound, and it's the sound that it hears goes through an algorithm, and then you get a conclusion of whether murmur is innocent or not. And these are available. However, I don't think the data are out there yet proving its use in the pediatric population. So I look and ask, should there be a new paradigm for murmur evaluation? Should there be a change in the way current providers are trained in murmur evaluation? And as an educator, I keep on thinking about this. And then we may, I think with the use of a lot of testing, is anybody really trained in simple auscultation? And do we need to retrain graduates who may have not had that type of training? And maybe we need to use a mastery learning approach. I'm going to put these questions out there for everybody to think about. My final thoughts, though, are the exam is useful. It should be a lifetime of practice and refinement. Try not to overuse testing. Testing tends to be more expensive, and you open up Pandora's box. And I think there's work to be done in reviving the cardiac exam with competency-based mastery learning or relearning. I'm going to stop now, but I'm going to go through I've got other slides, and this is for later reading and reference. So I'm going to go through about 2 seconds with each slide. I'm not going to read them all because I figured this is recorded. Folks can actually look at each one of these slides and pause it, and they can look individually. So I've got some tips. I've got some thoughts about murmur evaluation and evaluation strategy for the neonate, just some, after watching this, just some things to work. Remember, in the end, your exam has to stand by itself. Your history, it's your history. Sort of a strategy for the child or young adult. I've got some murmurs descriptions of all the murmurs I just pointed out: the pulmonary flow murmur, Stills murmur, PPS murmur, cranial carotid bruits, a venous hum, cardiorespiratory murmur. I've got some references for further practice. There's also simulator mannequins if you can find one. There's YouTube, there's the internet. We've got some murmur websites. We've got references on the use of testing. So this, I've read a lot of literature to prepare this talk in the past and currently. In fact, I recently wrote a book chapter. This is everybody. I'm not going to go through all these studies. It goes on and on. And that's it. I'm open for questions.
Thank you, Dr. Koenig. That was excellent information. I think we all have learned some great resources for how to test for the murmurs. I just was wanting to know, since you rely so much on listening for the murmurs, is telemedicine a good type of exam to detect for heart murmurs or manage the heart murmurs?
Great question. And I've thought about that. And that was one of my issues with telemedicine. Because I've seen a patient, it's only what I can see. I guess if I could train a parent to use a stethoscope and then transmit the sounds to me, and if I could trust that, I guess it could work. And then we have stethoscopes that can record things. So I'd reserve that. I said it's potentially, but I'm thinking not so much, because you have to know where to place the stethoscope. And there's so many things where I'm using my hand, and I think it's a skill that still needs to be done in person.
Okay, thank you. I'd like to invite any of our attendees to type in any questions if they have them. In the meantime, I can just let you know that Dr. Koenig sees patients at the main hospital down at Silver Cross Hospital in New Lenox, and does also do some general cardiology telemedicine visits. Dr. Koenig, do you work at all with our second opinion clinic at Lurie?
I do not. I mean, I offer second opinions. They come to my office, but no, it's something that, it's, again, my job description. I'm happy to do it. But I think we've got some individuals that sort of, they built it into their schedule.
Okay, sounds good. At this point, it doesn't look like we have any other questions. Dr. Koenig does have his contact information on the slide that's up in front of you. You can call the Division of Cardiology direct phone number. You can email Dr. Koenig send him an Epic in-basket message, connect with him on Rapid Connect, and also use our 1-855-LURIE-MD to reach the Lurie cardiologist who's on call. So I want to thank everybody for attending our session today. Yes.
Dr. Taji's raised his hand. He'd like to talk, and I'm going to unmute him so he could ask a question, okay?
Oh, thank you.
Go ahead, doctor.
Okay, go ahead.
Is a electronic stethoscope is better if we use that, or is that the same way it works?
I've actually used some electronic stethoscope because I wanted to record things for students. And I wonder, the two questions with electronic, I imagine you're talking like stethoscopes that record. There's one is what do you hear primarily, and the number two is what do you hear after it's recorded. And I'm assuming you're not talking about the artificial intelligence stethoscope. So when I used the electronic stethoscopes, I found that the initial quality was reasonable, maybe not as good as my stethoscope that I use, but it was reasonable. But I remember when I did the playback of the recordings, it deteriorated. It really lost a lot of the nuances in the sounds that it would hear primarily or with my own stethoscope. So I would use a regular stethoscope.
Regular stethoscope. Thank you. Thank you.
Thank you. I don't think I have any other questions or hands up at this time. I want to thank everybody for attending this session today, and we have recorded this session and we will have it available to you tomorrow. You'll receive an email with all of the pediatric roundtable discussions with the Heart Center. So look forward to our next series coming out in several weeks. And I just want to thank again everybody for participating in our event. Enjoy the rest of your day. Thank you.